to say hi to Shirin, who will take over and lead us through this really interesting event. The floor is yours, Shirin.
Thank you so much, Maria Isabel. Everybody can hear me well? Good, excellent, great. It's good to see the faces and also the nods. So again, I'm adding my welcome to Maria Isabel's. Thank you so much for joining this webinar. We are very excited to have this webinar. This is a topic that obviously is a great interest to you, but it's also very close to our heart, and we are very passionate about it at GENDRO. Just a few words about GENDRO. GENDRO is a non-for-profit organization based in Geneva. And it was born simply out of a shared concern that more must be done to ensure that any evidence that is produced to improve and advance our society, be it through academic research or policy analysis or programmatic evaluation, must take into account the significance of sex and gender in order to inform the development of equitable solutions to the societal challenges of our time. And today we are facing one of those major challenges, a difficult one, one of the most difficult ones perhaps in modern history. As we enter this new decade, we face not only a new virus and a new pandemic, but also a whole new reality that has changed every aspect of our life. The COVID pandemic has reminded us once again that sex and gender are critical determinants of health, and it's also exposed the entrenched inequities in our societies, the deep-rooted gender inequalities, from higher risk of death in men to an increase in violence against women and LGBT individuals, to ill-fit personal protective equipment for female healthcare workers, or the disproportionate burden of care that many of us probably recognize. With the gendered implications of this outbreak takes different shapes and forms. And not unsimilar to past outbreaks, such as the HIV one, SARS, influenza, and Ebola, in COVID-2, we witnessed that there is a combination of both biological sex differences, but also social and structural gender dynamics, gender inequalities, that results in differential experiences and outcomes for women, men, and gender diverse people, not only in terms of physical and mental health, but also social and economic well-being. And these gendered experiences are also further varied by age, by countries, and also influenced by other variables such as race, ethnicity, sexual orientation, disability, income, and so on and so forth. And we've seen actually an amplification of efforts and calls and guidelines and webinars around gender-sensitive response, the gender aspects of the epidemic, and even high-level commitments as statements by the WHO's Director General, Dr. Tedros, for example. And while these are quite welcome and important, we also know that designing more effective and gender inclusive approaches requires a robust and solid evidence base. And unfortunately, so far, sex disaggregated data and research that adequately takes into account gender dimensions are quite rare and difficult to find. For example, according to a recent WHO Gender and COVID Advocacy brief, only 40% of nearly 3.6 million infected cases that have been reported through the global surveillance system to WHO includes information about sex and gender, despite the fact that the surveillance form that WHO submits to countries and requires that information from the countries. There are also several COVID-19 live data tracking websites. You probably have seen or follow some of those, that they're providing rather real-time data on number of new and accumulated infections and deaths, and rarely any of them disaggregated data by sex and age, even for incidence or mortality, not to mention that data disaggregated by sex or age for other aspects of the pandemic, testing, symptom, hospitalization, or other social and economic kind of indicators are actually very difficult to find. And there has been more than 7,000 peer-reviewed papers on the pandemic just over the past few months. And this is a huge increase compared to other fields and other areas. And while I have not done a systematic review of all these 7,000, believe me when I said that I've read quite a few of these papers, and I can say with confidence that it's very unlikely that more than a fraction of these actually meaningfully address gender aspects. And history has shown us what we miss when we are gender blind. Examples of how symptoms of heart attack in women have been missed, how drugs have been withdrawn from the market because of greater risk for side effects in women, to underdiagnosis of certain mental health conditions in men and the disproportionate impact of HIV or other adverse health impacts on the LGBT community. We have plenty of evidence to teach us why we must do better. And we also have important lessons learned from what we gain in terms of efficiency, effectiveness, human lives and health outcomes if and when we apply a gender lens. So that brings me to that question. So why are we still talking about this after having so much fact and evidence, and we do know about that? Why is it still so difficult for us to do a better job collecting and reporting and using gender data? And that's what I think we should talk about today. During our webinar, we want to have an interactive discussion on gender, evidence, and COVID-19 with a focus on what we know, what we need to know, what lessons have we learned from previous large-scale outbreaks, what are the challenges in producing and using gender data, and what can we do to enhance collection and use of gender data and research in times of COVID. We have a great lineup of speakers. We will start with a 5 to 7 minutes presentation by each speaker and then follow up with an interactive discussion. As Maria mentioned, please raise your hand if you want to have an intervention. We will ask you to, we will read your name if it is, we can see that, and allow you to unmute and make your interventions or ask your questions. You can also share your questions on the chat box and we can read it for you if you prefer. Great that you have your cameras on. I also think that it's much nicer to see faces than just the screen when speakers speak. So without further ado, I would like to introduce our first speaker, Dr. Anna Ruggieri, a senior researcher at the Center for Gender-Specific Medicine at Italian National Institute of Health. If I'm not mistaken, Anna has a doctorate in virology and a dedicated researcher in gender medicine, and she's also a scientific coordinator of the project entitled Sex Differences in Response to Vaccination, pilot study on healthcare workers in 3 representative geographies in Italy. And I will talk about what we know and what we don't know with respect to COVID and gender, and sharing her experiences from Italy. And I hope we have solved our technical problem. Anna, can we hear you? Oh no, we still can't hear you, unfortunately. Do you have a possibility to call from a phone or a different computer? So apologies for the chat. Let me see.
Yeah, Anna.
No.
If you can actually, if you can call in with a phone, try to call in with a phone, and we go with the next speaker.
We cannot hear you through your phone either. Oh, that is odd. So can I, in the meantime, while we hopefully solve the issue with Anna's, we can maybe invite our next speakers, and then we'll kind of connect with you perhaps separately, Anna, to see what might the problem be. So our next speaker is Catherine Nyambura from ATHENA Network. She identifies as a Pan-African and pluralistic feminist with an academic background in public health, with 10 years of experience working on women and girls' health and rights, including sexual and reproductive health and HIV prevention, care and treatment. Catherine also leads ATHENA Network's advocacy and communication, and she will talk about how COVID pandemic affecting women and girls, drawing from lessons from the past outbreaks. So the floor is yours, Catherine.
Thank you so much, everyone, for joining the webinar this afternoon. I'm honored to be speaking today. Apologies, I will not be on video. I'm having a few challenges on that front, but I do hope that you will appreciate my insights. So just to dive right in and to appreciate Shirin for the very in-depth and nuanced analysis of the gender dynamics of COVID-19. And just to jump in and give a few specific examples of some of the work we are doing and working with adolescent girls and young women across Eastern and Southern Africa on some of the COVID-19 response we are doing. I guess what is important to affirm and confirm is that the violence against women that's being reported as the shadow pandemic is really important to also unpack what the impacts look like of violence against women and girls at this time. So we do have an increase in intimate partner violence. And I think for me, it's important to remember that the figures of 1 in 3 women will experience violence in their lifetime is one of the important points to refer to when alluding, when pushing for the need for gender data, because it means that either that figure is it's confirmed now or it's become more. And also just to unpack that violence and gender-based violence is really happening in different ways: domestic violence, structural violence. I think governments have responded in different with different measures and restrictions such as lockdown, curfew. Some countries have a mixed and mashup of both. And all of those measures do have their own impact on what kind of violence women are exposed to. We have seen increased rates of maternal deaths in some parts. We've seen decreased rates of institutionalized kind of violence, women being forced, sex for food, and we've seen other forms of violence like police brutality, all of this predisposing women who, for example, are the ones who will be the traders found out after curfew time. So I think it's important to emphasize the increased violence at this time and what that means for women and girls. And just stepping back to what COVID has done in terms of straining public health systems, measures on put forward by government, shifting resources, health resources to COVID-19 means that there's less financing, there's less resources for SRHR commodities. Disrupted global supply chains has led to lack of ARV supply. It has led to increased commodities for SRHR, which means that we are facing, and Guttmacher has put forward an article about 9.7 possible million intended pregnancies after the pandemic. So those are figures to reflect on and what that means at this time. And during COVID-19, it's also important to remember that the two measures that have been put forward, hand washing and social distancing, are a luxury for many people in communities where people have to share communal toilets, for girls who live in cash economies and may not be able to access sanitary towels at this time, for girls who have to choose between access to information in terms of buying data and buying food. And so it's important to see how all these factors and components amplify gendered violence. And I think for me, it's important to also remember that the unequal access to reliable information, especially for structurally discriminated and marginalized groups, means that not everybody is able to access the up-to-date information, and not everybody is able to prevent and protect themselves, protect their families equally. And just to narrow a bit down to, for example, adolescent girls and young women living with HIV, the messaging in the beginning and the confusion about exposure risk for those living with HIV has driven structural discrimination and HIV-related stigma along with COVID-19. And so I think that, along with lack of treatment and forced disclosures for people who do have to move between towns or during lockdown and curfew context, has made it difficult to access the prevention, care, and treatment that girls need and women need as well. And we also have reports of adolescent girls and young women who identify as LGBTQ facing heightened stigma in lockdown and confinement in abusive households, which amplifies the stigma as we've talked about. And so I just to step into what we've learned from the HIV and Ebola response and Zika and other pandemics before, is that we've learned we have to rely on a community response, and mostly we have to step back into a demedicalized approach. And we are pushing for the same for COVID-19. However, it's crucial to note that these systems, such as the community responses, are proven to work, are built on the backs of women and girls, quite literally, because it's adolescents, it's women and girls who have to provide care when public health systems are broken. That means they are exposing and putting their lives at risk. Also, women and girls step up to provide care because public health systems are broken down. And so unpaid care work is not just a function of gender norms, it is also a function of state failure and a way of subsidizing state investment. So I think it's important for us to start framing what this looks like. At the same time, we know that women do comprise 70% of global health workforce, while at the same time not equitably represented in the leadership of the same. So I think for me, it's a critical question to ask ourselves, why those who are modeling for us community responses are not the ones leading those responses themselves. And so fully understand these impacts and ensure a gender-just response, quality gender data is crucial, because COVID-19 is deepening, it's exacerbating already existing inequalities. Women were already working at home. Now they have to work at home and from home, not getting increased visibility in the workplace, not getting the same and not getting any infrastructure for support. So it's important for us to think of what gender responsive public infrastructure looks like all across. And just to talk about some of the lessons we've learned from the HIV is that the importance of putting communities at the center and their efforts is important, and that should be done meaningfully through communication and consultation. And that includes all those who are affected, including adolescent girls and young women. And I speak of adolescent girls and young women because I know when you talk about gender, there are layers to discrimination. While we do have women exist in intersecting and multiple identities. So it's important for us to unpack how the pandemic is affecting women, it's affecting girls, it's affecting women with disabilities, it's affecting gender non-conforming person. So it's critical for us to keep that lens going. At the same time, it's important, the lessons we've learned of confronting and being articulate about the impact of stigma and discrimination and the drivers on pandemics like COVID and others such as like HIV is important. So we should ensure that the communication that's put out is clear, crisp, and does not reinforce any existing or structural discrimination. And the other point is that a human rights-based approach rather than a coercive approach is what we need for a holistic response. And my last point is that data, including gender data, is a tool that could unlock and drive political actions and investments. Because gender data is critical for fueling advocacy and to push for gender responsive public health systems, public infrastructure, and equitable decision making. Therefore, while we can make a justification that we need data for evidence-based advocacy, we also need to go beyond making a technical argument to stepping into the political realm, which is about being accountable to all citizens, including women and girls, because women and girls pay taxes. Women and girls are the ones who vote for the leaders we have. So I think, and at the same time, we don't have gender inequality because we don't have enough data. I think my argument as a feminist is that we have gender inequality because we have not made a decision that women and girls' lives matter enough for us to engender our systems. So as I wrap up, I would like to mention that it is important for us to identify the indicators necessary to understand the social and economic impact of the crisis on women and girls. And finally, consider the quality and availability of the data we have and do better for women and girls, because COVID-19 is not the start. For one of my colleagues says it very eloquently. For women and girls, we have had different COVIDs. This is the only one that has made everybody across the globe, have to reflect and discuss what we need for the betterment of humanity. So in a way, it's also an opportunity for us to redesign and think of what a gender equal new normal looks for everybody across the world. So, thank you very much. Over to you, Shirin.
Thank you so much. I was on mute, sorry. Thank you so much, Catherine, for those really powerful presentations around the impact of the COVID on women and girls worldwide. I'm sure there are going to be lots of important discussions and comments on that, so we'll come back to that. So next, shall we go back to Anna? Oh, we still have a problem, Anna. Can we call you perhaps on your phone and put you on the speaker? Can we do that?
Can you send me your number, Anna, by the chat, through the chat, and I call you?
Excellent, we do that. In the meantime, then we can maybe move on to our next speaker to save time, and then hopefully we'll solve the issue, the technical problems back. Our next speaker is Dr. Stephen Burrell, Assistant Professor in Research at the Center for Research into Violence and Abuse in Durham University's Department of Sociology. His work focuses on men, masculinities, and violence, and on engaging men and boys in ending men's violence against women. His current research project focuses on the role that the business sector can play in prevention of violence and building gender equality. Stephen will speak about the impact of COVID on men's health, but also how research on the masculinity issues can help everybody. So please, Stephen, the floor is yours.
Thank you. Can you hear me okay? Great. I'll share my screen because I do have a presentation. Okay. Okay, great. Hopefully everyone can see that okay. Just shout if there's any issues. Yeah, so as Shirin says, I'll just talk a little bit about, I suppose, because of course a gender analysis also enables us to understand, the ways in which men are being affected in times of crisis like this, for example, and the role that masculinities play in influencing that, and influencing, I suppose, the wider societal impact and response to COVID-19. Can I switch my slide? Yes. Okay. Yeah. So I suppose, first of all, the most obvious thing, I suppose, to say here is that, it does seem like in different countries across the world, more men are dying from COVID-19 than women. Although I think it's worth just mentioning there that actually that isn't necessarily the case in every country. There are a few countries where it's more even or even slightly the other way, like Canada and Finland. But of course, this just first of all highlights the need, as Shirin has said, for sex disaggregated data for us to really be able to understand that, not just in terms of deaths, of course, but who are the people that are getting infected and what symptoms are they experiencing, how might those be different, for example. And also, I suppose, not just disaggregating data in terms of sex and gender, but also in terms of other social categories and forms of inequality, such as race and ethnicity or socioeconomic status, sexuality, because we know, it seems to be the case that, this isn't just a simple picture of more men dying, because actually it's some men who are much more vulnerable to this than others, such as, men from working class backgrounds, men from ethnic minority backgrounds. So the picture is more clear. We need the data to understand that. Yeah, and so more, I suppose not the point here is that it's not just sex disaggregated data we need, but kind of more gender sensitive data and research more broadly to really get into some of these gendered issues and help us to understand what's going on there. Whether that is in terms of some of the biological differences that might be influencing COVID-19, such as it seems like, women's immune systems might be doing a better job of fending off the virus. So, but as Shirin kind of already highlighted, a lot of medical research traditionally has been, taking men as the default really, and not doing as much research on women and women's bodies. So we still have a lot of catching up to do there. And I suppose that's really important to highlight, when we're thinking things about like researching vaccines, is that being done with women and men equally? Is it being done with pregnant women, for example, to understand how that's impacting them potentially in different ways? Yeah, and of course we know as well from previous research on men and masculinities that kind of norms around masculinity, impact upon the health and well-being of men and boys in all sorts of different ways, and are likely to be heightening a lot of the risks which are presented by COVID-19, whether that's by contributing to some of the kind of underlying health conditions which seem to be associated with the kind of COVID-19 having a more harmful effect, things like cardiovascular conditions, for example, or respiratory conditions. So for example, men are more likely to engage in things like smoking and drinking, and that's to do with masculine norms, and that then obviously has an impact on their health. So that's one really important thing to be taking into account. Also, it's, research suggests that men are less likely to wash our hands and engage in other kinds of hygiene practices like that. It might not be seen as kind of masculine to be constantly washing your hands, for example. And so obviously that's something really important at the moment. Also, I suppose more broadly, we know that, men are more reluctant to seek help, whether that's in terms of going to the doctor if they're experiencing physical health problems, or seeking support from friends and family if they're suffering from mental health problems, which obviously is a huge issue at the moment with so many of us kind of isolated at home, potentially on our own, for example. And also, I suppose sometimes, oh yeah, sorry, I will slow down a bit. Thank you. I suppose the other thing to mention as well is that early research suggests that men may be taking coronavirus less seriously at times, and therefore taking some of the precautions against it less seriously as well. So things like social distancing or wearing a mask. Again, you know, if men are pressured to be kind of tough and stoical and independent and, you know, not in need of help, then things like wearing a mask or not wanting to meet up with your friends because of the virus might not be seen as very masculine things to do. And I suppose, you know, you look no further than some of our world leaders to see an example of that, you know, who aren't willing to wear masks, for example, or who haven't been very taking the virus particularly seriously, at least in the beginning of their country's responses to it. And I suppose, as has already been discussed, of course, you know, masculinities don't only influence men's health and well-being. I mean, gender is relational, so what affects men affects women, and vice versa. And I suppose one of the most obvious ways in which that's the case is in terms of gender-based violence, which is clearly being exacerbated by the current crisis. And as was mentioned in the previous presentation, you know, this shouldn't really be any surprise. Like if we look at other outbreaks in the past, you know, that similar issues have arisen. And I suppose it perhaps just shows how at times governments, you know, have failed really to take on a gendered analysis, because this seems to have been a bit of an afterthought for them really in thinking about the impacts of policy responses like introducing lockdowns, for example. So whether that's increases it or kind of exacerbating intimate partner violence or child sexual abuse, so like violence in the home, of course, was most of us being isolated at home, but also other forms of violence and abuse as well. For example, online, such as online harassment, you know, through Zoom, for example, has been a big issue. People using technologies to kind of aid with like stalking behaviors, for example. Also things like image-based sexual abuse. So there's been suggestions that that might be increasing at the moment. For example, like things like so-called revenge pornography. And I suppose maybe that's connected to, you know, with all of us being stuck at home most of the time, that there might be increases in the use of pornography as well. And so what impact is that having on men's behavior in particular? And also, you know, not to forget about violence in public as well. So there have been reports, you know, that women and girls are actually experiencing more public sexual harassment at the moment. You know, if the streets are quieter, men may feel more kind of able to engage in that kind of behavior. So I suppose that for me, the two important things to highlight there is that the pandemic presents like increased opportunities, you know, for men who may already be perpetrating something like domestic abuse, for example, to exert power over their partners or their children. And also, I suppose, you know, some men may feel kind of threatened by the crisis in different ways, you know, whether that's economically or in terms of obviously just the impact it's having on all of our lives. And you know, with power and control being so central still to constructions of masculinity, they may feel the need to kind of try and reassert masculine dominance over others in order to kind of deal with that. And so that can contribute to these problems as well. And then I suppose another area which I think is really important to highlight here is if we think more, I suppose, about gender inequalities more broadly, both in the home and also at work, and how those are being kind of, well, as was already mentioned by Shirin, you know, how all forms of social inequality currently are being exacerbated and are also making the impacts of the crisis of COVID-19 itself worse as well. And so one area in which we can see that currently is, of course, you know, with schools being closed, for example, and childcare facilities being closed, you know, increased caring responsibilities are obviously needed there in the home. And of course, it's women who are mainly the ones who are having to deal with that. And that in turn is then having a knock-on effect in terms of workplace inequalities. I mean, just for example, in academia, in my workplace, a lot of, you may well have seen this already, that a lot of academic journals are reporting that they're getting lots of article submissions from male academics, but a decrease in submissions from female academics, because, you know, the women are probably more likely to be having to look after children at the moment. And also, of course, women are more likely to be on the kind of front line, as it were, in dealing with the pandemic, in terms of those kind of key workers working in sectors of society, which are obviously at the moment being shown to be absolutely crucial in terms of health and social care, for example, but which have been neglected for so long, you know, in terms of pay, for example, perhaps partly because they are seen as kind of feminine forms of work, and therefore they aren't valued as much. But at the same time, you know, some men at least may be playing an increased role in things like care for others, whether that's for their children or for family members, or I suppose engaging in wider community support, for example, as well. And so I feel like, you know, maybe this could present a chance to really shift some of the kind of masculine and gender norms that we have and encourage men to play a more active role in caregiving. And also, I suppose another thing just to highlight here is that it is really important to adopt a kind of intersectional approach to understanding all of these different problems. So not just the virus itself, of course, but also, you know, for example, I feel like in a lot of the coverage we've seen, it has been quite heteronormative. Like there's been a lot of a focus on, well, how are heterosexual couples and kind of nuclear families dealing with this? But we haven't seen as much about how are LGBT people experiencing this and how are inequalities they face being exacerbated as well, for example. And so, yeah, for example, LGBT people's experiences of domestic abuse, you know, they're likely to be facing greater problems there as well. And is there support in place for them at the moment, for example? And so, yeah, just to conclude, I suppose, the other thing I think is really important to highlight is certainly in a lot of countries, certainly here in the UK, for example, you know, we are seeing kind of responses to the crisis being dominated by men's voices a lot of the time in government, for example. And also, I suppose, more broadly, kind of quite masculinist approaches in terms of how we respond to the pandemic. So just one example of that is this common use of kind of like wartime language, you know, we're fighting a battle against the virus and so on. And I suppose, you know, there is a danger there that could lead to real kind of policy impacts, which could actually make gender inequality worse. So, you know, this has been an issue with previous crises as well, like the financial crisis a decade ago, you know, whereby, for example, kind of male-dominated sectors of the economy might be prioritized when it comes to like government support measures, for example, even though actually it seems like it's the service sector and therefore jobs which are more likely to be done by women are actually being hardest hit at the moment. And also that government policies like financial support schemes might be based on a kind of breadwinner model as well. So, for example, you know, women are more likely to be in kind of precarious jobs, for example, which might often kind of fall through the net in terms of some of the government support schemes which exist at the moment. And so again, and I suppose just another example there in terms of that male breadwinner model being influential, like here in the UK last week, the government said, oh, we're actively encouraging people to go back to work now. And yet schools are all still closed. So it's like, well, how are people who are looking after children going to be able to go back to work? So it's almost like they're assuming that somebody, probably the mother, is going to be staying at home to look after the children whilst somebody else, probably the man, goes out to do the work kind of thing. So we really need to be challenging that. And again, I suppose that shows the need for gender data on all of these things. You know, how are the economic measures being introduced currently? How are those impacting on people differently based on gender, for example? But at the same time, I think, you know, the crisis is bringing into question some of the kind of masculinist assumptions which underpin our societies. So, you know, it's really showing how interconnected we all are and how dependent we are on each other for our survival, I suppose, and how important community is and care is for our kind of survival, essentially. And so I suppose for me, the question therefore is, you know, might the pandemic lead to kind of fostering more kind of caring, egalitarian and sustainable societies as well, of course, which is actually absolutely crucial in terms of trying to stave off a climate crisis down the road as well. And I suppose for me, that's a question because that could happen, but it's only going to happen if we all try to kind of, I suppose, fight to make that happen. Yeah, so thank you very much for listening. I hope I didn't go on for too long. Thank you. Oh, and I'll stop sharing my screen, of course.
Great, thank you so much, Stephen, for a very interesting presentation. And again, I think a lot of thoughtful comments and thought-provoking comments and ideas that I think we will definitely discuss after the next presentation. Let's see if we can get Anna back.
Yes, so I will try to get her through my phone. So let's try that because the microphone didn't work, but let's see if that works in any way. Okay.
Yes. Yes, we can hear you, Anna.
Okay, let's share the screen. Okay, here we are. Can you hear and see my slide?
Yes, we can hear you. We cannot see your slide yet, at least I can't. Coming along, great. Yes, I think we can see that now. Thank you so much. Please go ahead.
Yes.
Can you see the slide? Can you see my slide? My first slide is okay?
Yes, and then we can see your slide.
Okay, so I'm sorry for so much trouble with the connection with Zoom. Anyway, thank you for the invitation to this exciting webinar. And let's start with the internal situation with regard to the gender and COVID-19. We are, among the European countries, in Italy, we are the first country in Europe that we have an approved law and a national plan for the dissemination and application of gender medicine throughout the country. And the Ministry of Health, together with the Center for Gender Specific Medicine and the Italian Institute of Health, is creating a national observatory with the aim to ensure promotion, maintenance, and monitoring of all the actions included into the plan. And with regard to the COVID-19 integrated surveillance in Italy, this is a surveillance that has been established soon after the pandemic started and is published weekly by the Italian NIH. And they provide, in this case, the percentage, the data disaggregated by sex regarding the percentage of case confirmed of COVID-19. And from this analysis, it's evident that female patients, women are much more infected than men. And this is probably due, of course, to a bias in the tested population that is made mainly by females, because it includes healthcare workers, and also probably because women, as similarly to the previous epidemic, are much more exposed to the infection because they work as familiar workers, and they also take care of elder people in the family and also work as domestic care workers. And with regard to the absolute number of deaths among the COVID-19 patients in Italy, in the surveillance, integrated surveillance, in the national integrated surveillance, the data provided disaggregated by sex and also age. And in all age groups, it is evident that there is a male bias. So men die much more than women. And with regard to on the right side, the case fatality rate, that is the ratio between the confirmed death and confirmed cases. So it is a measure of the severity of the disease. It is evident that in all age groups, the case fatality rate is significantly higher in men than in women. The only exception is in the absolute number in the over 90s because of the demographic composition, because there are more women in the over 90s. And in people with severe COVID-19 disease, an association with pre-existing comorbidities, including cardiovascular diseases, pulmonary chronic disease, chronic renal failure, hypertension, obesity, and so on, has been found. And the Italian data provide the most common observed comorbidities in SARS-CoV-2 positive disease patients disaggregated by sex, pointing to an evident higher percentage of men with specific comorbidities such as ischemic heart disease or pulmonary and renal failure, while in other cases like hypertension and obesity in Italian population, there are much more women that disease because of COVID having this type of specific comorbidities. And an important point in evaluating the gender bias in COVID-19 disease, it is the admission to intensive care units for symptomatic COVID patients. In Italy, actually, these data are not provided at the national level. I mean, we don't have the same analysis that we have for death and comorbidities or percentage of infection. But actually, I found some data that were published in April that were on a population of intensive care unit admitted patients in Lombardia, that is the most affected region in Italy, in the north of Italy. And it is evident from this analysis that included less than 1,600 patients, that those patients were mainly men. So men in all age groups considered in the study were more than 4 times more than women in having been admitted to the ICU. This is thanks to Shirin for providing me this slide that is in regards to the Spain situation. Actually, in Spain, where the impact of the COVID pandemic is similar to Italy, the national data provided is aggregated by sex, not only for comorbidities and risk factors, but also for the symptoms. And this is a very important point, because the disease presentation is different between men and women, and this is a very important point for the rapid diagnosis. Another critical point, at the point that I want to share with you, is the clinical trials for COVID-19 and the sex disaggregated data. Probably we all of us know that there are many clinical trials ongoing all over the world for some therapeutic intervention for COVID-19. In Italy, we have 29 clinical trials approved by the Italian FDA. In all trials, men and women are included, but there is no idea to have sex disaggregated data for the analysis and the outcome of the data. Actually, we know that the adverse effects of drugs and vaccines are more intense in women than in men, and it is also reasonable to assume that at least in some cases the adverse events can be overcome by adjusting the dose of the drug. So do we have governmental guidelines on that? Actually, in Italy, it seems that we don't have, but I know that there are no governmental guidelines to provide the sex disaggregated data of the outcome of the clinical trials all over the world. Also in US, there are no official guidelines on that. And we also have a focus on the transgender population, health population, and we are going to start a national survey on the transgender health in Italy, collecting the data about the healthcare and needs, and also including some questions about personal experience with COVID-19 pandemics, including infection information and also interaction with the therapies. And also we are going to start in a few days the first institutional website in Europe dedicated to the transgender population, that is the InfoTrans. So in order to provide some an effort and to contribute to the effort of the Italian National Institute of Health in giving some disaggregated data with regard to the COVID pandemic, we also prepare some recommendation for collection of the disaggregated data for the incidence response to therapy, and also provide some hypothesis and explanation of the difference between men and women, especially for the number of deaths because of COVID. So we identified some gender-related factors that are linked to lifestyle, such as smoking addiction, that is more frequent in men, or social and work mention that are like caregivers or healthcare workers, more frequently women. And also we pointed attention also to some biological sex factors, such as immune responses to virus that are usually lower in males than females, and genetic factors linked to X chromosome encoded genes and that are involved in SARS-CoV-2 virus attachment and entry into the target cell, as well as sex hormones, estrogens and progesterones that modulate the immune response, and also some expression of critical factors for infection by the SARS-CoV-2 virus. And finally, I can say that the law and the national plan has been a victory for all of us who have worked and believed in gender medicine. And also we hope really that the law and the healthcare plan soon could become a milestone for European countries and a reference for Western countries, and also for those countries where the therapeutic appropriateness is a chimera or a hope so far. And sorry for the inconvenience of the connection, and thank you for the attention.
Many thanks, Anna, for a very interesting presentation. Again, myself, I have a lot of questions for you, but before asking them, I suggest that we move on to the next speaker, our last but not least important speaker, Ricardo. So Ricardo Baruch is Regional Advocacy Officer for Latin America and the Caribbean at the International Planned Parenthood Federation, Western Hemisphere region. Ricardo has been an activist and a researcher on LGBT rights and other SRHR issues for more than 15 years, collaborating with different civil society organizations and networks. Ricardo will speak on an important subject on the impact of the pandemic on the LGBT community and how to ensure a more inclusive understanding of gender when we advocate for a gender-sensitive research. So Ricardo, the floor is yours.
Hi, everyone. Good morning from Mexico City. It's a pleasure to be here with you and share this space with wonderful panelists. And first of all, I just want to remind us all that just a couple of days ago was the International Day Against Homophobia. So I think it's a great opportunity to actually talk about like LGBT issues in the context of the COVID pandemic. And I think that also something that I just wanted to mention before I actually start, it's the fact that a lot of people know about the work of IPPF, the International Planned Parenthood Federation, as an organization working on sexual and reproductive health, but we're also have like a new commitment to work on LGBT health and rights as a federation, which is very interesting because there's like this new reform that we have in the organization, and we're really committed to like strengthen our work in that area. So in that sense is that I will talk a little bit about some of the data that it's available or is not available and why regarding LGBT people. So first of all, let me start saying that in general, there's not a lot of data about LGBTIQ plus people. And the reason why is that there's, of course, the level of recognition of LGBT rights in different countries, as you know, is really different from one place to another. So for example, in some countries where they're like, where LGBT rights are recognized, like for example, in the constitution, in national laws, there is a registration, for example, of like in the census about like how many LGBT people it's out there. There are like registration, for example, of how many same-sex couples have got married, how many transgender people have gone through gender reassignment. But in many countries where LGBT rights are not recognized, of course, there are no numbers. There's only like, for example, UNAIDS has some estimates of how many MSM, men who have sex with men, or trans people are, but that does not include, for example, lesbian women, or that not includes transgender men, because in theory, they're not at risk as MSM and transgender people. So that's to start with, that's a huge problem. And of course, like usually the only things that are data that is available in some of those countries, for example, in most countries in Africa and some countries in Asia, is about like how many people from how many MSM and transgender are living with HIV or sexually transmitted infections, but that's not counted in any other health-related issue or except in some other spaces, including many European countries and many countries in the Americas. So far, there's no evidence if there's like a specific vulnerability of LGBT people to the COVID pandemic. Of course, we know that they are related to discrimination and violence. Those two things might be exacerbated because of the pandemic. And for example, there are situations that have been very visible. For example, in our region, countries like Panama, Colombia, and Peru have a gender separated like a quarantine. So for example, men can go out one day and women can go out the other day, but there have been many issues of transgender people, queer people, and non-binary people going out to buy groceries and being detained by the police, and some of them actually being beaten or being or being like shamed in social media for being out. If, for example, a trans woman who is clearly a woman goes out, but the police say, "Hey, no, you're a man, so you're not supposed to be out here." So that's, for example, one of the issues that we see. Of course, another big problem is the fact that a lot of LGBT people, particularly trans women, have very precarious jobs. Many of them in a lot of countries are doing sex work. And of course, the COVID pandemic is having a very strong impact in their lives, even stronger than, for example, those for LGBT people who are not, who don't have like a gender, a different gender identity. And another big problem regarding that data is the fact that, for example, the registration of the people who are dying because of the epidemic, of course, do not include sexual orientation or gender identity. And that's something that it's, as far as I know, it's not measured in any country. And of course, like even if that was a measure, there would be very unlikely that the family would actually say like, okay, my relative who just died was a gay man or a trans woman or something, because of course of issues of stigma, issues of discrimination, and of shame in general in the communities. And we've seen also how this stigma and discrimination is having like a strong impact in some countries. For example, what happened just a few days ago in South Korea, where there is like a new wave of cases of COVID-19, and apparently the space where the new this new wave began was a gay club, or well, a club very frequented by LGBT people. So a lot of Koreans were blaming the LGBT people for this new wave. And the same has happened in many countries where Muslim imams and like priests have been blaming the LGBT community for being the ones who provoked God's anger and brought us the pandemic. So that's something that it's very complicated and makes it even more difficult. For example, if we were trying to gather some data. On the other hand, there's definitely new surveys that have been implemented by civil society organization, by research and academia, just like what Anna mentioned just a few minutes ago, that in Italy they will begin a survey for trans people. But of course, there's always this issue about like how the, for example, online surveys are not necessarily reaching all the people that that we need to reach, particularly if we consider that there might be a considerable number, for example, of people living in the street who belong to the LGBT community, who do not have access, of course, to the internet, to even to a smartphone and so on, in order to respond to service. So we also really, I think we also need to do a stronger effort during and after the pandemic to gather the data from all LGBT people, and not only, of course, those who have more regular access to the internet, who, by the way, of course, might be less vulnerable to other situations. So just let me finish by saying that there are already some recommendations, for example, by UN Human Rights, in the case of the Americans, by the Pan American Health Organization, which is part of the World Health Organization, which of course we're this week will be in the global focus because of WHA. They have recommended to do as much as possible to disaggregate data also by sexual orientation, or at least by gender identity, which is something that it might be more tangible for some people. And I think that that's really important to see the differentiated impacts of the epidemic. And that's something that, of course, like I think that many of the organizations will be working towards in the next few months. So hopefully we will have more accurate data on LGBT people and the impacts of the epidemic in the next few months. So thank you again for the invitation, and really happy to hear the comments and questions.
Thank you so much, Ricardo, for sharing these important dimensions and challenges with respect to data collection around LGBT dimensions and perspective. I'm sure we're going to have a lot of discussions around that too. With that, I would like us to kind of open up for a discussion and questions from the audience. And while people are kind of maybe thinking around and formulating their questions, can I just ask, I mean, let me start by Catherine. Catherine, are you still with us before you leave? I know that you might need to leave early.
Yes, I am here. Thank you.
Great. Thank you so much, Catherine. I just want to kind of come back to the issue around the women and girls. Again, you mentioned a lot around that we have seen similar trends around the exacerbating the gender inequalities, the impact on women and girls from the past outbreaks. What have we learned, and how are we using those lessons in this current pandemic to kind of improve our response? What are your views on that?
I think my views is on the importance of gender responsive public health system. So from the Ebola and Zika pandemics, we have seen that sometimes women and girls are forced to step back from productive, quote unquote, productive work for them to take up caregiving roles. Because and that means that it's a case of inequitable access to healthcare. It's a case of normalizing caregiving duties, and in the same trend we've seen with COVID-19, the case of COVID-19 being found in semen, the same happened for Ebola, and so that puts as Stephen mentioned, it's relational. That's because for heterosexual women and girls, it means they will have exposure. For heterosexual women and girls who cannot negotiate safer sex, that combined with compounded instances of violence against women, intimate partner violence, means that we would end up with a double or twin pandemic, right? We will end up with later a shift where we might have women being exposed both from sexual front and from the caregiving front. So it's important for us. And we've also seen it with the HIV when there wasn't access to treatment, and the women and girls had to first model the concept of support groups in community. And that meant that a lot of them didn't have the resources. Like currently, we do not have the PPEs as we are seeing. They didn't have the resources to protect themselves as frontline workers or as community workers. So there is the importance for us as we model the community responses, as we model a space where we are working with trained and fraught public health systems. We do have to ensure that information is shared equally. We are investing in existing public health infrastructure outside the medical systems. We know that in context where I am in, we rely a lot on community health workers, community health volunteers. They do not have formal medical training. Most of them are women. They do not have what you would call salaried positions, but they are part of the response, as you would call it. We do have a lot of people currently, young women, young people in the community providing support in terms of distributing food packages, distributing menstrual health products, distributing other kinds of health products. And in that way, if they don't have information to spread, adequate, accurate information to spread. And in an instance where we are learning about the pandemic as everything is unfolding, there is need for equitable access to information, and there is need for equitable access to protective care, and also resources. I think for me, it's the interdependence between health, water and sanitation, and all these other things we've been discussing at this time. And just to, I think for me, the biggest success, or the one thing that has been reinforced now, is the importance of care. The focusing more important on care work and paid care work. We have seen more countries in the recent past, maybe because of SDGs, roll out surveys, time use surveys. So this is one thing that should be maybe scaled up after COVID-19, because care work has definitely multiplied in different ways and across all households. And so it's important for us to start considering the contribution of care economy into GDPs. At this time, if we only consider hardcore numbers as to how we are quantifying success, yet everybody now has to work both from home and at home. We know home is not the safest place for everybody. And I think the other thing that I would push for is maybe adapting innovations in the sense that we should take up the innovations that are being modeled in communities. So we have seen communities where those who are delivering food packages are, producing questionnaires to determine whether women are exposed to violence, and initiating systems of support through those kinds of things. So I think for me there's lessons, but also there are things that we cannot afford to replicate as blind spots because they've been said for so long. And I think it's sort of the pervasiveness of gender inequality and patriarchal norms and systems, because for us to be saying it over and over again is an issue of now power analysis just beyond gender social norms. So I think for me there's that importance for us to reflect deeply and maybe use the tools we have to get the data we need. And then finally, before I step back, we know that a lot of women's rights organizations produce data, but how data systems are set up in countries, this data is not considered official. So because we have to rely on Kenya, on demographic health service, we have to rely on official census data. And so the data we produce through different projects, through different systems has not been considered official data yet. And I know in my country where I am in Kenya, there's a whole negotiation between non-state actors and state actors as to how you can navigate the realm of officializing and unofficial data. That's another point that we should step in to ramp up and ensure we do have the gender data we need to make the decisions that are equitable across everyone. So thank you.
Thank you, Catherine. We have an interesting question here that is to you, but also maybe for the whole group from Equit Act. I don't know if Equit Act, do you want to kind of pose your question yourself or do you want me to read it?
Hi, Shirin, it's Sarah.
Oh, hi, Sarah.
Hi. I think it was just what I'm saying is, and I think, Catherine, you just actually touched on it. For me, it's like, and having worked in a policy environment, ministries are at national and at state level and in other functions. Ministries will come back and choose to ignore the data, or as you say it's not official data when it suits them, or to say we don't have enough data to answer the question, go away. We do have enough data to point us in the right direction, that the systems are not effective because, we've got these differences, that it's clear that they're not gender sensitive. So how much evidence is enough to get them to act? And particularly at a time when, we're seeing around gender equality and SDG 5 and other things, there's actually a backlash towards gender equality in a lot of countries and discussing that. So do other people have views about how much evidence is enough to get them to act? And then when because we do have it, and they are collecting it, when they've got people who are dead in front of them, they know whether they're self-identified male or female. And then we have the other discussion, putting aside for a moment the other discussion that we just had about how people identify otherwise. So when they say they don't have it, it's not true. It's just like lack of will to act, lack of will to use the data. Like I've been told before by other people, and you were saying, Shirin, there's not enough columns. If we disaggregate the data, there's not enough columns. It's like, I'm sorry, but like it's only one other column if we're going with the binary notion. So like, how do we learn to challenge that kind of, that gender resistance in an effective way? Sorry, I've talked for too long.
Who wants to go ahead first? And maybe on top of that also, how do we actually better use available data? Because it's also not about only collecting and reporting the data, but also effectively using them to shape our response or future kind of data collection efforts or any policy and programs. I think we are also very bad in using the available data. It's not only a problem of collection. Yeah, Catherine, before you leave, you want to kind of maybe respond to that, since that was a little bit of a follow-up to your presentation and talk, and then we'll also kind of come back to both Ricardo, Stephen, and Anna on that.
So yeah, I do want to respond. I think in my experience working on the issue of gender data in Kenya and across different African countries, I have realized that one, the quote unquote gender space is one that's has not been very open for a long time. At least not to young people, not to women's rights organizations, because it has been seen as a technical space, as you need some sort of qualification to be able to engage. And this can be seen, for example, with the SDG process, where it was open for the open working group. It was open until we had the SDGs, but when it came to discussing the indicators where the rubber meets the road, it wasn't as open and transparent for engagement with civil society, including women's rights organizations. And so it means that the first thing to do is to democratize the data space, including the gender data space. That's number one. And number two is this important issue that that's being raised of, we have data that exists for so long, and I think in so many ways, in so many platforms, in so many in different packages, and on different issues on women's rights, on HIV, on health, and it hasn't been utilized to make decisions simply because of the way the government has designed data cycles. And I think for me that's a political advocacy issue. For a long time, there wasn't so many civil society engaging to push governments in terms of adopting data as part of the data cycles. And so it has opened up a whole realm for data advocacy. Increasingly, I think with the onset of SDGs, the past few years, we have seen much more feminist activists engage with this space, learn how to use data visualization, because I think it's one thing to collect data, it's another thing to utilize it, it's another thing to visualize it and even understand how to use it. And so for somebody like me who works with women and girls and young women, especially adolescent girls and young women, we have to find ways that the data speaks to people's reality. Because data is political, if you ask me. In many ways, in countries where laws are homophobic, they will not want to count how many people, they will not have data on LGBTQ and LGBT people, because that is one way of invisibilizing a certain part of the population. You know, the data on 1 in 3 women will experience violence in their lifetime has become like a slogan for the movement, because it was available and it was packaged in a way that people can remember that figure. And I think for me, we've seen people figure out how to make data more interactive, crowdsource information and be much more inclusive, and make tools for collecting data much more affordable. So I think there is and also without everybody becoming, an information systems expert. That's the other point, because that's also the kind of barriers women and girls face when they try to enter into the quote unquote data space. So it's important for us to demystify this space, have open channels with government as to what that process of democratizing and officializing data looks like. I know there has been discussion on methodology, even the way the SDGs are set up, tier 1, tier 2, tier 3, such simple agreements would be able to enable that we are all able to track processes collectively and be accountable across board. So I think for me, it's important also to just take the data we have and analyze it before we even start talking about collecting again, because for a long time, everybody and in some sort of way is collecting information and data. Maybe we just need to strengthen systems around that. And thanks everybody for joining the webinar. It's been really wonderful being part of this panel and this discussion.
Thank you so much, Catherine, for your insightful comments. Ricardo, do you want to kind of follow up on that? Because I think that this issue around data collection and also use that evidence for government, in particular in countries or settings where it is less welcoming or even punitive in somehow, it's even more challenging. Do you want to kind of talk about that a little?
Sure. And also, I actually want to go a step back, because we see how in this world there are like so many political leaders who are just ignoring the evidence that's out there. So like I think that the best two examples, of course, are Trump and Bolsonaro in Brazil. Like, for example, Brazil is one of those countries who has taken many years building very strong systems for collecting data. They have like very strong researchers, very strong academic institutions, and still, despite all the data that's available, the president just decides that he doesn't want to hear, and they will do something completely different. And the same case in the US. So I think that that's a different story. That for example, in Latin America, we're seeing that not only those two countries, but many other countries with authoritarian regimes, including Venezuela, Nicaragua, and nowadays El Salvador and Mexico. They're basically, like, if we don't strengthen the democratic ways of making sure that the politicians listen to the data, including the data that their own institutions create, for example, the ministries of health, the ministries of gender, then we're not going to get anywhere. So for example, here in Mexico, like in the morning, you will hear the minister of gender saying like, oh, the situation for gender-based violence is getting much worse. We have this data. And in the afternoon, the president during a press conference will say like, oh no, everything is okay. Families are caring and everybody is enjoying during this difficult time. So it's just, like a very difficult situation. And of course, in regards to the LGBT people, it's even harder, right? So like, I think that we really need to make more noise and make sure that our voices are heard, but also we really need to make sure that we put people in the government that will actually like take decision based on evidence and not just in their own beliefs.
Thank you. Stephen and Anna, I also want to take your your take on that. Anna, Italy has been one of those countries that, of course, was very heavily affected by the COVID, but also you have a law around gender medicine and data collection. How does that get implemented? And what do you think we can learn for lessons around the using of those data being collected in informing the response by the government? And also to Stephen, how does your research around masculinity, is it that, again, men's voice sometimes take precedence over other kind of research, or what do you think your research around men's health and masculinity can inform the policies in a way that can also improve or impact the programs and policies for the broader community, including women and the LGBT community? Anna, you want to go first?
Can you hear me?
Yep.
So just to be sure, I will give you my opinion, and then if you want, I can also call the intervention of one colleague of mine, Professor Malorni, and also some other colleagues involved in the transgender and the survey. So maybe they have much more clues than me. Anyway, my opinion is that, we need to use in the best way all the data we collect. In Italy, as I told, we have a law, and so we are a little we are the only one country in Europe to having a law for gender medicine and a national plan for application of the gender medicine in all fields. And I think that the way we did was collect the data and the evidence more than the data at first. And as much evidence, not only experimental, but also observational data involving all colleagues or people that have interest in the topic. And then we try to sensitize the decision maker and the politicians. This was the way that we did. And finally, after continuous and not really short, but not so long way, we succeeded to have some politicians that try to make a plan, a national plan for the application of the gender medicine in the health and also in other fields. And also another point is that we need to share all the information, all the observation that we have, and to trying to, through mass media, to information and scientific publication, all the channels that we have to share the observation, because still in Italy, where we have a law since 2 years and we have a plan since last year, still many people and also clinicians, they don't know what is gender medicine, what we are talking about. But another point is that is economic point, is that if we want to collect and analyze data always disaggregated by sex and gender, of course it is more costly, because sometimes in some cases we need to do double work, not only for one population, but for two different populations, and also for the therapy, or if we think to clinical trials, we need to extend the number of people involved in the trials, or animal models involved in the trials. So everything is more costly and also maybe time consuming. But what we need to stress is that it is worth to do. It is necessary so far. So if you want, you can get involved in the discussion, Dr. Malorni and Dr. Pier Dominici. I'm sure my director, Dr. Alessandra Carré, maybe they have some clues more than me.
May I make a comment? Can you hear me?
Yes, please go ahead.
What I would like to say is that what Anna is saying is very important. The need of a network. We have a big network in Italy and a small network in Europe. There is an international gender medicine society, and I think that this could be very important to try to improve our database, but also to try to improve our interplay with the political makers. One example, the idea is that the drug agency here in Italy, but the same is at the European Agency for Drugs, there are no commitments to include women in trials, or at least to stratify the data for depending on sex. So that there is something that we have to do, we must do politically. We have to have a strong network able to say that, to underscore the relevance of this approach, at least for drugs, but not only for drugs. I have a question, and after that I stop. For Stephen, there is another question, which is that, let me say, the day after. We are going out from the lockdown in several countries, at least here in Europe, and there is a day after that. I think it's I'm in trouble for this, since all the questions and the points raised by colleagues are very important and should contain not only the state of arts now, but I'm afraid that in the next 2 months, we have a sort of rebound, a sort of wave that could be very long. And it's very important that other skills, such as sociology or economics, or this network should be not only for medical doctors or for biological doctors, but only for all the other skills that are needed to improve our consciousness and in general, the fact that the differences between the two sexes could be sort of can cover all the area of our society. Okay, thanks.
Stephen.
Yes, well, yeah, thank you, Walter. I mean, you highlighted exactly what I was going to say already, actually, that as with the other speakers, I think, unfortunately, we do have to recognize that a lot of these decisions being made are highly political. And so obviously we need more data and research, but at the same time, there's a lot of stuff we already know, which politicians are ignoring. And that is a political decision. So for example, here in the UK, like the government has been very keen to repeatedly emphasize, like, we're following the science, we're doing what the experts are telling us. But the experts that they're listening to is often, quite a narrow pool of voices from particular fields. So yeah, they haven't been listening at all as far as, really to social scientists, for example. I mean, obviously, as a sociologist, I'm like keen to emphasize the importance of us. But, obviously, there are so many social issues and inequalities which are being kind of made worse by the current situation. And at least here in the UK, the government has failed to take those into account. And I suppose similarly, I suppose researchers need to therefore be kind of having the confidence to say, well, look, our research is relevant to this. And if that's certainly the case with regards to gender-related issues and gender inequalities. And in terms of, because yeah, maybe on that, with that aspect, maybe one thing which comes to my mind, which could be helpful, is you know, this is really, I suppose, really exposing how relational gender is, and how issues around masculinity, for example, do have massive impacts on men's health as well as for women's health and everyone's health. So maybe, you know, that could be used, hopefully, to try and shift some thinking in terms of policymakers, for example, to get them to, you know, because it's very, maybe they find it easy to kind of marginalize feminist voices by just associating that with like women's issues, which society doesn't take seriously. But if we can show actually these are issues which we're all facing, and if we take on board these feminist arguments, then the whole of society will benefit. You know, maybe that could get some more kind of people listening. And I suppose just the other thing I suppose I would say is, well, yeah, that shows the need, therefore, you know, for political action and campaigning and advocacy on these issues. But maybe we can try and illustrate some of the positive examples we're seeing at the moment as well. You know, the amazing ways people are responding currently in terms of like community support, for example, and in terms of shifting gender norms, like some of the ways in which men are kind of currently, you know, maybe some men are engaging more in caring activities or are trying to support their communities or their kind of friends, for example, trying to challenge some of those masculine norms. I think that can be really powerful, you know, as showing some positive examples of how people are doing things differently and how that's effective. Yeah.
Let me say just one thing. The next international meeting of gender medicine that I realize is something more than the simply medicine. I want to underscore this fact. Will be, I hope, in 21 in Italy, and I hope it could be an interdisciplinary issue in which we can have a stronger interplay between different disciplines and try to improve this interplay. Okay, so I think that we must have an open mind on this issue of gender as it's a social, it's economic, it's a medical, but it's a biological and so on. So it's very difficult to put together all these skills. However, I hope that in the next meeting, international meeting, which would be in Italy, I hope that we can join there and discuss all together.
Absolutely. Thank you so much. I'm mindful about time. Just want to thank everybody for a really interesting presentation, a very dynamic discussion. There are a lot of areas we need to still continue discussing about. I think there was an agreement that we do need a cross-disciplinary approach to kind of bring in expertise from different areas when we are dealing with outbreaks and health crises of such a magnitude. But also a note that perhaps as researchers and public health or global health officials or actors, we also need to be activists. There is also not only a technical matter of collecting and using data, there is also a political act to make sure that these data can really inform the production and the implementation and design of evidence-based, gender-sensitive policies and approaches. And I think that's an important call for everybody. I want to maybe give one last 1 minute closing remarks to our speakers. What should we do? What are the next steps for us to make sure that we can produce, use, and make sure that our responses are more gender sensitive? So let's start from Ricardo at the end and then go back to Stephen and Anna.
Sure. Well, I think that something really important that we need to learn is for something that happened in the HIV epidemic in terms of like once we showed that the differentiated impacts in some key populations, such as transgender women, sex workers, drug users, who usually were not being measured for anything. Like the HIV epidemic taught us that it was really important to start doing research around those groups, to do to gather data about them, but that came from the communities. We were the ones who were fighting for that, and eventually we got it. So I think this is something that we can see if at some point we can do as well with the COVID pandemic. So let's make sure that the communities are included and are part of the response. Thank you.
Thank you, Anna.
Sorry. Yeah, you're good.
Can you hear me? Yes.
Yes.
Yes. Sorry, your question. I missed your question.
No, just a closing remark. What can we do? What can we do to improve our gender data, the production, but also use of data to influence a gender responsive approach?
Oh, thank you. And I think that the best way is to make a big network and to build a local, national network and also European network and worldwide network among all the fields involved in the gender issue. I think the networking is what works much more. And with regard to the minorities or to the special population, I think we need to let them trust the institutions, let them trust the investigators, as we did and we are actually continue to do with the Infotrans, with our experience in this field. I think this is very important, and it is a very hard, long, and constant work that we have to do. And we should be serious, no speculation at all on that. So networking and working with the minorities, but let them trust in us.
Thank you, Anna. Stephen?
Yeah, I would just say, I suppose, just doing whatever we can just to make gender visible. And I suppose the pandemic in that sense is such an important moment, because there are so many ways in which gender is clearly, playing out at the moment, which we can clearly point to. So just making that case as much as we can. And of course, then linking that to the other forms of social inequality, which it's intersecting with. And I suppose, as a man, I think, we as men have a particular responsibility as well to say, well, these issues which feminists have been raising for a very long time are hugely important, and actually they affect us as well. And maybe trying to instigate a bit of change, in that respect among our peers, for example, all the way up, of course, to the leaders who are still, dominated by men.
Great, thank you so much for those final comments. We are in an interconnected way, and gender connects us all by so many different levels, both in the society, but also through our work and our shared interest. So please continue the conversation on our social media, on Twitter and Facebook. Stay connected. Most importantly, the GENDRO has put up a statement around the importance of gender-sensitive data. Please visit our website and endorse that statement. And I'm looking forward to continue this conversation with you online, but also hopefully offline at the next Gender Medicine Conference and also other fora. And keep up the good work, everybody. Thank you so much for joining the call. Thanks so much for all our speakers and our audience for listening, and looking forward to connecting with you in the future.
Maybe just one, quick
Yes.
last comment.
Of course, Maria Isabel, sorry. And thanks for Think Tank Hub for hosting us.
No, don't worry. I was just, because I received some comments, if you can look it up online. So either you look on Facebook, it was live stream, so you can find it there, and it will still be available either on the side of the Think Tank Hub, or on the side of GENDRO as well, I think. And we will put it online also at www.thinktankhubgeneva.org. So if you want to look that up again, it will be available there as well.
Great. And to all the other participants who had questions which we never had the chance to address, please feel free to either connect with the speakers on social media or post your comments on Facebook. Perhaps we can also reach out to the speakers and ask them to respond to those online so we can continue the conversation. Thank you again, everybody. Thank you, the GENDRO team, Zioda and Claudia and Kala, and the Geneva Think Tank Hub team, Maxime, Marine, and Maria Isabel, for making this session possible. And again, wishing you all a wonderful afternoon or day or evening, wherever you are.
Thank you. Bye.
Bye.
Bye.